we are going to launch a new version of our mobile application. And whenever we do clinical practice, we are often challenged with scenarios where we don't remember everything, we don't understand the approach, and we don't understand the figures. We want to use some calculator, and it's very difficult to do it on a day-to-day basis. Now, I always thought that when you are managing a case, like a challenging case comes to you, let's say of a persistent hyperinsulinism, the conventional approach is that you go back to the books, start reading from there, try to get back, and then decide how to manage. The problem of this approach is that most of the time you'll start off with pathophysiology, then you will go on to what are the causes, then you will go to evaluation. So by the time you reach to the management, it becomes difficult. So what we have been trying to do and what we have been thinking for over a decade is to bring those algorithms that have been developed into real practice, which make it very easy and to do it on a point of care fashion. These are relevant predominantly for people who have less exposure in pediatric endocrinology, but also helpful for everybody. So if you're using it and you're sure that this is the way it should go in a precise manner, the applications will help out. So we started around 5 years ago, and today we're going to start off with many new formats of these interpreters, which will allow us immediate evaluation and management on that perspective. So over the next 2 hours or so, we are going to really highlight how these solutions can help out in terms of our day-to-day pediatric endocrine care. Now, why we started thinking of developing these tools was this case, whom I managed when I came back immediately, maybe 15, 16 years ago, was this 7-year-old boy with short stature who came to us at a time when nothing could be done, in that the bones were fused. Now, this is not unusual. Still, 10 to 15% children come to us at a very late stage. What was unfortunate in this case was that he had all the features of celiac disease. He was TTG positive, but unfortunately, because of the severe anemia he had, that was maybe around 5 to 6 years ago, he was evaluated by a pediatrician who advised blood transfusion, which culminated into HIV/AIDS. So a reversible thing, a very simple thing like celiac disease turned out to be in a very adverse scenario. And that made us think what could have gone wrong and how could we have improved in that regards. So the most important thing in terms of the improvement of care of any particular individual with a health disorder is awareness. If the patient is aware at the right time when to go to the doctor, if the doctor is aware what things to order, how to evaluate, we can prevent most of the things. Accessibility to specialists is number two. Affordability is last. So often people think of pediatric endocrinology that you need very expensive investigations in a very complicated scenario, which is not true. If you do it at the right time, you can identify in that regards. Now, how do we really have a true evidence-based clinical practice? For that, there are multiple things that we need to implement. Of course, there are large amount of books which are available. You have to put all that knowledge back into clinical practice. This involves ordering rational tests, especially in resource poor settings where you can't just order every test all the time. You have to use that in terms of algorithms. You have to understand about the various drugs, the interaction, how to use, what dose to use, and then finally you have to take everything up to make that. So the process of a rational management of a child with endocrine disorders, of any child, requires a comprehensive combination of diagnostic, therapeutics, approach, management. All this perspective is important. So we tried to build up resources which will help us in terms of overall improvement of pediatric endocrine care initially in the country, and then beyond that. So we started with workshops. So we have conducted over 200 workshops across the country, but that itself is a very tedious process, and the retention of people is not a long time. So they will forget. Maybe once you do a workshop, 1 week later, everything is gone because they're not implementing in the clinical practice. We started with practical courses. So 15 courses have been done in the country, but they are extremely resource intensive. You would need a lot of time, energy, money, everything. So it's not easily feasible. We started with a YouTube program which provides a lot of free channels. So this is also there. We started an on-site fellowship. So till now we have 14 fellows who have joined. So this is something, but then again, the reach is limited. To take it forward, we started with our Medi classes, which was our online portal, which takes it beyond the routine classroom to beyond, so that people can use that knowledge and understand in a systematic fashion, brought up the textbooks. But then at the end of it, what we realize is that unless and until we have something in the hands of a physician at the time of management, they would not be able to take the implement all this knowledge, because knowledge is there. Unless you see it day in and out, then it's in your reflex. Otherwise, you will forget. So then we thought 5 years ago to develop a mobile application, which at that time was a unique way of managing cases, and still now it is one of the very rare ones in that perspective. So as I said, we have done a lot of pediatrician initiatives across India and abroad, including a lot of workshops, practical courses, advanced courses in that perspective. Our e-learning portal has got huge number of videos and a lot of watch time. We have organized learning, which is a validated program at learning.growsociety.in, which offers courses for pediatric endocrinology to various aspects, starting from the fellowship program to small fragmented courses in that regards. And these have been accessed from people across the globe, which has culminated in that. We have got 3 publications, both basic, advanced, and protocols, which form the basis of many of these applications. So all these algorithms that we use now are largely based upon many guidelines plus clinical experience, and many of these are already published in these books. So we have used that to translate these books right away for clinical management. So the Mediclasses Endocrinology was the app which was basically released around 5 years ago. It is the most downloaded pediatric endocrinology app, or an endocrinology app, so to speak, with 10,000 installs. There are multiple places where it has been presented, multiple awards have been given. There are publications also which have come out from there. Now, the crux of this app is to try to translate what knowledge is in terms of clinical practice. So the most important ones which started off were approach pathways. Now, how these approach pathways were working were like these flowcharts. So there will be questions which people will answer, and based upon those question answer, we would be able to achieve the diagnosis in that perspective. And this is how you will read. So based upon your results, the next question will come up, and then subsequent to that, a final diagnosis will come up. So this was a stepwise approach. It simplified the algorithm. Now, if you have, let's say, algorithm pasted in front of you also, it may be more difficult, but if you get precise answers, it made it much easier in that regard. So there are covering entire parts of pediatric endocrinology in the approach pathway. There are management pathways similarly, because many of these scenarios, like if you think of increased insulin effect, how do you decide which workup to do, what to do? So we developed these management pathways. This allows implementation of algorithmic approaches and management on a clinical basis. So it gives you a personalized guidance. Now, the problem with these pathways is, which I don't think it's a problem, it's part of their way they have been developed, is that it will take a bit more time and you will have to put inputs every time. This is an advantage also, because then you can get a much more detailed picture of the clinical scenario. But often in this day and age, we want instantaneous results, that we want immediately that you input the data and you get the output. So for that, what we tried to develop was interpreters. And one of these interpreters is like thyroid interpreter, which Dr. Vibha will talk a bit more, in which what you do is that you just enter your analysis, and based upon that, you will get the diagnosis as to what you're dealing with. We have now largely taken forward a number of interpreters, and this time which we are going to launch is interpreters which are holistic approaches for complete electrolyte disorders in a single interpreter, hypoglycemia, calcium, and these interpreters have become, they are instantaneously more helpful because they give immediate results. But we need to remember is that because they are based upon one-time input, they may not be as encompassing as compared to a approach pathway. So often if somebody uses that, like here what it says, follow approach pathway as well. So this is for the initial guidance, and then you can go ahead and use the approach pathway from that perspective. Now, of course, when we say that you do a particular test, let's say a AMH test, you need to understand when to do the test, how to do the test. So you don't want to go back to the book and open it up. We have a full diagnostic section which provides what is the timing, what is the sample type, what is the reference range, and everything is available within the app. So within a single app, you've got all the information. Similarly, if you want to prescribe a drug, there is a therapeutic section which really provides the detailed information. So all the drugs which are used in pediatric endocrinology are there, and we give all the adverse effects, interaction, and all those parts in that regards. Many times in pediatric endocrinology and other aspects, you want instantaneous calculation of things. And this is something which we have provided. And this is not only simple calculator, it is also helping us in scoring system. So like external masculinization score, often people will forget. Those who are not using it regularly won't remember. So here you will get what exactly you have to input and you will get the result. Similarly, bone age, this was a Achilles heel for pediatricians. So this was a major development which we did in terms of developing a bone age tool which uses only 5 sites to provide an accurate estimation of bone age, which can be done rapidly even via a non-expert. So this is something which has been used now across the globe. This has been published and validated, and we are going to make it even more simpler, hopefully soon. And things like Ferriman-Gallwey score, which may not be possible for the patient to examine right in the clinic, we can ask the patient to self-rate and they will give you a picture. So this is going to help you provide an objective estimate of clinical parameters. Now, many people say, okay, we now have a pathway, we now have interpreter, but we want to learn a lot. Now, what we have done is that entire knowledge bank, which is there in our website, is provided here as well. So if you want to read a particular thing without the figures, otherwise the load will become too big. The app will become a lot of GBs there. You have got all the textual information you can read about any particular condition. So entire knowledge pathway is there, and you can also test your knowledge using the mobile pathways in which questions are there, which scenarios can be used. So what we have tried to do is to bridge all the things, including diagnostics, therapeutics, approach, analytics, to get the clinical management based upon the latest state-of-the-art guidelines from that perspective. And this is something which we wanted to do. So a lot of awards have been given. So in 2019, we had the presentation as far as the bone age interpreter is concerned. Dr. Riddhi had presented that and won 2 awards, one from the IAP Research Conference and the Indian Society of Pediatric Endocrinology in 2019. Dr. Sayan won the award and the West Bengal IAP in 2022 regarding puberty interpreter. Then we had a good presentation on bone age in the novel tool used by Dr. Naveen at the Asia Pacific Pediatric Endocrine Society conference in Seoul. Dr. Vibha has been presenting many of these ones, including in the American Thyroid Association, including the thyroid interpreter. Then we had Dr. Alapan, who presented the diabetes interpreter at the Asia Pacific conference. Dr. Dhwani, who won the DSD interpreter. So a lot of publications have come out from there, including the growth chart, the DKA management, and the bone age assessment, and many more are on the way. So what we're going to do today is to try to cover a wide variety of pediatric endocrinology and how our tools can help us. So we have a child, 12-year-old girl, height is 132 centimeters, weight is 20 kgs. It's a common problem. Around 2.5% of all children are short. Most are physiological. 10% have a pathology. So the answer that we have to do as a pediatrician is to decide which does not require test and which requires test in that regards. So the most important, of course, we talked about is physiological, which is constitutional delay of puberty and growth of familial cause. And within pathological, we have got the primary problems in the growth plate, SGA, Turner, skeletal dysplasia, or secondary problem in the form of nutrition or endocrine. So the 3 questions to answer is it short stature? If it is short stature, is it physiological or pathological? And finally, primary or secondary. So to answer the first question, we tried to use pathological prevalence as a marker of what should be the criteria for short stature. So what we found is that as the height standard deviation score goes down from -2 to -3, the chances of pathology increase from 2.5% to 42% to 80.5%. So anybody who is less than -3 standard deviation has a red flag sign, needs immediate evaluation. And what we want to do through our app is to move away from percentiles and go more in favor of standard deviation score. Because when you talk about percentile, which is a good number figure, you're looking at a chart, but if somebody says less than first centile, it doesn't make any sense. When you say -6 SDS versus -3 SDS, you know there is a big difference in that perspective. So less than -3 standard deviation score is clearly a sign of worry. -2 to -3, you can follow up and look on that. 3 things to look at in a child with short stature to identify physiology versus pathology are growth chart, puberty, and bone age. And when we talk about growth chart, we look at 3 major things. What is the absolute status? How is the child compared to the population in terms of percentile and SDS? How is the child coping as compared to parents in terms of target height and target height SDS? And finally, what is the nutritional effect in terms of whether the weight is more affected or the height is more affected? Continuing with the theme that I've been talking about in terms of standard deviation score, our algorithms take into only SDS in consideration. So we take height SDS to decide whether the child is short or not. Less than -3 usually means pathological. More than -2 is normal. -2 to -3 is considered as intermediate. For the parental height, we use corrected height standard deviation score. So if you have a child whose corrected height standard deviation score is more than -1.5, this is a familial. So he is not short for the family. For nutritional, we use BMI standard deviation score. And if BMI standard deviation score is more than -1, this is endocrine, less than -1 is nutritional. So you will get a large number of outputs when you look at the growth interpreter. You will get information about height SDS, weight SDS, BMI SDS, target height, corrected height. And this is all the algorithms have been already loaded, and it will automatically tell you what is the pattern of growth failure. And our newer tools are going beyond that also to suggest the likely workup also from that perspective. Now, pubertal assessment is absolutely important. And we know that breast stage 2 is the most important aspect as far as girls' development is concerned. So we need to identify breast stage 2, which in the modern era should be through palpation. Conventional Tanner staging is via inspection, but now because of obesity, a lot of lipomastia is happening. So we want to do a palpation to confirm that there is a true breast tissue there or not. From there, we expect 20 centimeter growth. Then we have secondary mount, which is stage 4. You get 10 centimeters height gain there. And from menarche, the height gain is only 5 to 8 centimeters. So if you have a girl, which I often say has a height of 135 centimeters, at stage 2, she will land up 155. If she is stage 4, she will land up 145. If she is menarchal, it will be like 140 centimeters. So you need to really look at puberty when you decide whether you want to do some intervention or not. Now, often there is problem in terms of pubertal assessment, particularly in boys, where you need to really have a orchidometer to identify. So testicular volume of 4 ml indicates an increase in testicular size, and more than 10 ml will suggest that you need there is a time when the growth spurt has happened. What we have tried to do is to develop a tool with which you can easily interpret the puberty. You can compare the pubic hair and the breast development to get an accurate assessment. And this is particularly relevant in scenarios where the patient, it's not easy to do it because of privacy issues. So you can give it to the mother or the daughter or the child who can be able to self-rate her in that regards. And this is something which we have developed. The major problem which was there in terms of growth assessment and particularly validated growth assessment was the bone age assessment. And the problem there was that people are not really trained and the radiologists are not really that much wanting to spend that much time in terms of bone age assessment. So for bone age assessment, we need the left hand or the non-dominant hand, stretched fingers, and assess the maturation and the fusion of epiphysis. The single most important thing to look at is the difference between the epiphysis and the metaphysis of the phalanges. If somebody asks me which is the one side you want to look at, that will be middle finger, middle phalanges, and around 95% of bone age can be predicted by that. But what we try to do is that conventional methods like Tanner Whitehouse talk about 20 ones, while GP Atlas is comparing the whole thing. So we try to see if we can minimize the number of sites to reduce the amount of exposure in that regards. So GP Atlas is matching one to the other. Very common, most commonly used, particularly in North America, is GP Atlas. The problem is not all bones grow together. So if carpal is, suppose, let's say more mature and phalanges are less mature, then which one to use becomes a problem. That problem was addressed via the Tanner Whitehouse, in which each segment, a different segment of the bone was given a particular rating. So this was something which was quite helpful. And then finally, we have the automated bone expert, which is available. These are limited by the cost of them as well as the time which takes in that perspective. So we decided to develop a bone age application and validated this using 5 sites, which reduces the time of this test and gives us early results. So this is how you do it. You just have to compare 5 different sites, and then you have got the middle finger, middle phalanx, middle finger, proximal phalanx, thumb, radius, and ulna. And this takes approximately 2 minutes, even for a non-expert, with a good validation compared to the standard Tanner-Whitehouse method. This has been used a lot, and we've got a lot of publications coming out from that regards. So finally, when you have assessed the puberty, the growth, and the bone age, there are 3 questions to answer. Is the child short? If not short for the population, no workup. Then short for the family or not? If not short for the family, target height SDS. Its corrected height SDS is within 1.5 or target height, nothing to worry. Then finally, short for bone age. In that perspective, this will be CDGP or other perspective. And less than -2, you do a systemic disorder screening. And otherwise, you do a growth hormone stimulation test only if they are clinical parameters. So this I'm not going to detail exactly, but this is what is imprinted already in the growth interpreter. And the algorithm will then decide about what way to go forward in terms of evaluation and assessment and management from that regards. So this is the tool which we published in 2021, and we found a significant over 98% concordance of mobile application with the clinical diagnosis. So it was a way, you just have to enter a few details and you will get what is the likely diagnosis, evaluation, whatever I talked for the last 20 minutes or so, you will get it on a click of the button in that regards. I'll now invite Dr. Vibha to talk about our newer intervention that we are doing in the form of bone age assisted interpretation of growth.
To move one step forward, we decided to combine all three, like growth chart, pivotal status, and the bone age assessment into this big, which is the bone age assisted interpretation of growth. This is a very user-friendly web tool. This is not a mobile application. This is a web tool. Here, what we have to do, we have to just enter the key anthropometric parameters like weight, height, parental height, date of birth, and the pivotal status, which is done by the selection of specific image, as you can see for the breast, pubic hair, and also you have to click for the menarche status as well. Now, the second thing is to import the bone age. It could be done by the selection of 5 important sites that Sir has discussed. And the second method, you can manually input the bone age as well. So all these data is assessed and processed by the algorithm that has already been uploaded in the web tool, and which provide the instantaneous guidance on a single click as a pictorial growth chart that shows the mid-parental height, bone age, age, and weightage, along with the detailed interpretation of the growth parameters like BMI SDS, target height SDS, corrected height SDS for bone age, corrected height SDS for bone age, which are very important for the classification of the growth disorders, along with the bone age report. And the most important thing, it gives the most likely diagnosis, like for the growth interpretation and the puberty, along with the workup that has to be done in a particular scenario. It also provides the follow-up tracking, which is a unique feature of this application. So when we did the validation, we found that it was concordance in about 99% of the cases, and we see that it has shown a much better concordance as compared to the pediatric endocrinologist, pediatrician, and pediatric trainee. It has increased the concordance rate to about 96%. And the impact of the discordance, what we have seen this, it decreased the mispathology to 20% and the unnecessary burden in 20.4%. The errors that we was found, this normal puberty was diagnosed as the short or the precocious puberty, and the overdiagnosis of endocrinology etiology by the pediatrician and the pediatric trainee. The big has shown the reassurance and the follow-up in around 54.8% cases, and it has shown the misdiagnosis in only 6 cases. So we have this case of 12-year-old girl. The height is 132 centimeters and weight 20 kg. Father's height 163 centimeter and mother's 150 centimeters. As we know, the basic approach is to plot the growth chart, and we can see the Her height is below the third percentile, and if we see the mid-parental height, it is around 151 centimeter. The first question is to answer whether the child is short for the population or not. We can see it is below the third percentile, so definitely it look like this is short for the population. But the second question comes whether the child is short for the family or not. If we see the curves that the child lies within the upper and the lower limit of the mid-parental height, that means the child is not short for the family, but it is short for the population. And if we see for the height age, and which is 9 years, and the weight age, which is also 9 years, and it is lesser than the chronological age, which is 12 years. And if we put all these data in the app, it will show that the child is likely to be the familial short stature, along with the this chart with showing the BMI, height, and the weight. And here we can see the corrected height SGS is more than minus 1.6. That means that shows that this is the familial short stature pattern, not the endocrine or the other. Now coming to the second case, we have this 12-year-old girl with height 120 centimeter and the weight 15 kg. Mother height was 157 centimeter, father's 170 centimeter, and both bone age was 10 years. Here the hemoglobin was 10.2, TSH and TTG was normal. When the IGF-1 level was done, it was 15 nanogram per ml, and the growth hormone basal level was low. So the question is whether this child has a growth hormone deficiency or not.
So do you agree with GHD diagnosis in this case?
Definitely not. So we cannot rely on the single level of the growth hormone, basal growth hormone level. So here we can use our app to say whether it is growth hormone deficiency or not.
If we look at basically the key outputs that we look at is the weight. So the most important thing to look at in a child who is short is to look at the weight. So what we see here is that the BMI SDS is minus 3.7. And we have said that if your BMI SDS is below minus 1, then we are dealing with most likely a nutritional cause rather than an endocrine cause. So based upon whatever we discuss, or whatever Vibha has been talking about in the last 10 minutes or so, it's all incorporated in the app. It will give you the likely diagnosis. It will give you more precise figures. So the key message is you could plot on the chart to get the same information, but here you are getting more objective information in form of growth interpreter. Yeah, carry on.
So as the BMI SDS is minus 3.7, so definitely it is, and when the IGL level was done, it was indetectable. So definitely it is a nutritional pattern of growth failure. Now coming to the next question, here is a 10-year-old boy with a height of 100 centimeter and weight 18 kg. His mother height was 150 centimeter and father was 163 centimeter. He has a pretty delayed bone age of 7 years, and hemoglobin was 13.2, TTG and TSH was normal, and TTG was 32. He was put on gluten-free diet, but there was no effect.
So do you agree that this is celiac?
With the level of TTG 32, definitely not. And if it is a celiac, then definitely on a gluten-free diet, the height should have improved.
And the other thing would be the BMI.
BMI.
So what was the interpretation then?
So if we put all the data in the interpreter and we see the BMI, the BMI is more than minus 1.1, it is 0.6. So definitely it is not fitting into the criteria of nutritional pattern. And if we see, yeah, if we see the corrected height, this height is it is minus 5.68, and the corrected height SDH is minus 4.27. So it means this patient is lying in the more in the endocrine pattern of growth failure, not in the nutritional one.
BMI is 0.6, which again suggests that this is an endocrine
pattern. So definitely this is not a case of celiac disease.
Now, more of people think about that if you have technology, it is going to replace the physician. It's not going to. Technology is there to assist the physician. And if we do not move with the technology, then we may be left behind. So what our aim is definitely not to replace any clinician. It's just to support, aid, guide. Sometimes you're not sure about what the guidelines would suggest, what level is appropriate, how to do those calculations. The app is meant to help out. And it also specifically tells you where you need to seek a specialist opinion as well. So this is mainly to assist people at all levels. And our studies, if you look at the interpreters for DSD, for diabetes, it may also be helpful not only for the training pediatricians or the pediatricians, but even for endocrinologists and pediatric endocrinologists. So just to ensure that you have a continuous growth, you can just have a look as to what it is suggesting. And then final diagnosis treatment will depend upon, of course, the overall clinical scenario. So we encourage all of you to go and have a look at our MediClasses endocrinology app. It's available both on Android and iOS store. In the first 7 days, it's free for use for everybody. So you can have a look at it. And then it's available for subscription at a nominal fees in terms of the clinical perspective.